Good evening. Welcome to another episode of Book It Now. I'm your humble and gracious host, Q. I want to thank you all for joining me again today on this continued journey of empathy, growth, and understanding. Remember, if you would like to be a guest on the show, you can visit our website, www.bookitnowtv.com. We have a very special show today, a show I've been looking to for quite a while. As I know, most of you are affected by cancer. A lot of our family members, or if you have been affected yourself, this is something that has been a growing illness that has affected just about everyone, with 100 different types, over 100 different types, and can affect any part of the body. It's something that we don't talk enough about. So today we have two radiation oncologists joining us, Dr. Alison LaVigne and Dr. Jacquelyn Dunmore Griffith, who are both the radiation oncologists. They'll be sharing a bit about their story, and we're going to be talking about cancer prevention, and how to best go about treating this disease at its varying levels of stages and different parts of the body. So I want to thank you all for joining me today.
Thank you for asking.
Yes. Thank you. First, we'd like to start at the beginning. So what brought you to become doctors, and why this specialization?
For me, I think it all started in high school. I loved chemistry. I love science in general, but definitely chemistry. So that's what I decided to major in college. And then I had to kind of figure out, what am I going to do with it?
Right.
You know, so it was either research, but then I was kind of guided in the direction of working with people. I like working with people. And the college I went to, that was its emphasis, was placing minorities in medical school. Xavier University in New Orleans.
Okay. Yeah.
And my sister is also a physician, so that was an influence there as well.
Really? And what about yourself, Jacquelyn?
My father was a physician. I grew up in a family pretty much of medically related people. Dad a physician, my mom was a nurse. My sister went on to medical school before me, so I knew early on that I wanted to be a doctor, just because it was what I had been exposed to, and the thought of helping people was really what I wanted to do. So I sort of went down that path, or at least that's what I thought I was going to do. I had a little curveball here and there, so I didn't go straight to medical school after college. I took maybe 2 or 3 years before I went. And Alison and I actually have been friends since elementary school.
Really?
Yeah, so growing up, we spent quite a bit of time together. Like, really, I think we met in fifth grade. And either I was at her house or she was at my house throughout high school. And then we went to separate colleges, separate medical schools, but we reconnected in terms of training. So she had gone into radiation oncology before me, and she introduced me to the area. And I was like, yeah, I like this. So she's responsible actually for me going into radiation oncology.
Really? So what was it about that experience, her bringing you into that environment, that said, okay, I like this enough to pursue it? You know, there's one thing to enjoy it, but to pursue it and make a career out of it is...
I think personality has a lot to do with it, too. As she said, we're both service-driven, and we wanted to give back to our communities. And when you go to medical school and you're doing your third and fourth year, when you're doing your clinical rotations, that's when you get to really be exposed to the specialties.
Right,
and decide what is it that you want to do with the rest of your life.
Sure.
So I liked radiation oncology because the patient population that you're serving, I think I had a personality where I am empathetic. I can relate. I treated every patient like they were my family. What would I want for my family member if given the fact that they had been diagnosed with cancer? And then with radiation oncology specifically, I think it gave us a nice combination of different medical specialties, because I didn't want to be a surgeon, but I like going into the OR doing procedures. So with radiation oncology, we get to do procedures in the operating room. So it allowed me to continue to do those type of techniques. It's pretty much an outpatient type of setting, and I knew having a family at home was going to be very important too. So some type of specialty that was 8 to 5, but still allowed me to do different things. And I think
maintain that
radiation
balance.
oncology was a nice mix.
Wonderful. And what was it like? I'm going to point this at you first here, Alison. For you to grow up through this experience and being a minority, well, and even a double minority, right? In some environments.
Well, I guess, my experience in terms of arriving at radiation oncology was I went to medical school in Southern California,
Okay.
University of California, Irvine. And our medical school actually had a huge radiation oncology department I didn't know anything about because you're not really exposed to it,
Right.
pardon the pun. To that specialty.
Right.
So I wasn't sure exactly what I wanted to do, except I knew, and this is going to sound a little dated, but I knew I wanted to have a family, and I kind of knew more of what I didn't want to do.
Okay.
So I'm from Washington, D.C., and I decided, okay, I love Southern California, but it was time I was ready to come home. So the only program I applied to was Howard, and Howard only took one resident a year. And I was fortunate enough to get that spot.
Wow.
And so, and what impressed me about Howard, and the reason I was so bent on going there is because of the minority women in specific
Sure.
that I met there. It was just a very, very impressive women in medicine there, and in radiation particularly. So that's really how I ended up there.
Wonderful. Wonderful. Well, I kind of want to get into the topic here now. I'm sure a lot of people, when they're learning about cancer, their first question is, what is the first sign? Is that consistent? I know there's a lot of different types and a lot of different variations here, but is there a consistent first sign that people should be looking for?
Well, if it's caught early enough, a lot of times patients don't have symptoms. They're picked up on screening. That's the best situation to be in. But some common symptoms would be, losing weight. That's a common one. Or a skin lesion that changes. It, like you said, there's so many different kinds.
Sure.
Coughing up blood, urinating blood. Pain. But that's usually indicative of something that's a little more advanced. The goal, and we're definitely seeing that in the last decades. I mean, Jackie and I, we did our residencies 30 years ago, and just in our own span of our career, we have seen the strides.
Sure.
And just the general population is just much more educated, and so they know, and they're educated about screenings, and they're doing better about trying to mitigate some of those lifestyle changes that they need to make to prevent cancer.
Yeah, so I mean, there are screening guidelines. So,
Sure.
some of the most common cancers are breast cancer, colon cancer, lung cancer, prostate cancer, and each of those, and even cervical cancer. So each of those have definite recommendations as to how you should be screened.
Okay.
So again, like Dr. LaVigne or like Alison was saying, the best scenario is if something's picked up during your screening, because then that means you have not become symptomatic. So we're
Right.
catching it really at the earliest stage. And the earlier the stage that you can identify a cancer, the better control you can have with that cancer.
And for those, I guess, just to use the examples, the breast cancer, pancreatic, for screenings, should people be going to get screenings at certain points of their lives, like prostate exams, for example, when, there's a certain point where, okay, this is start time for me to start paying attention to
Definitely. So for prostate, they generally recommend that men start screening at age 40.
this? Okay.
Particularly in African American men. And unfortunately, in several different cancers, minorities fare worse. So, like, for example, when they may recommend that women start getting screening mammographies for breast cancer, which is an x-ray of the breast, at, say, 50 or even 40, we're seeing, Jackie and I are seeing women in their 30s, sometimes even in their late 20s, that have the most aggressive type of breast cancer.
Really?
Yeah, so screenings are important. One trend that I've noticed, even in my own practice, and I also read about it, is colorectal cancer. That recommendation, they just lowered the age to 45. But historically, it had been at 50. That's when they say you should start getting colonoscopies, unless you have a family history.
Right.
But I have treated in the last 2 years at least 4 patients in their 30s, and they've all been African American patients. And so they just lowered that screening age. And I've even had this conversation with my own children to really pay close attention to any changes in their bodies, because those younger patients tend to be diagnosed in later stages because the doctors aren't thinking about it. So they're delayed. Yeah.
And so, so there are screening guidelines that give age criteria, and we tend to say, because we deal with a large African American population and we both trained at Howard, even though we go by the guidelines, sometimes you have to bend the rules. So you have to know your family history, for instance. So if you have a strong family history, usually you'll start getting screened anywhere from 5 to 10 years earlier than the recommended age, okay? And then you have to pay attention to your body. If you know something just doesn't feel right, it doesn't seem right, and you go to the doctor and you're in your 20s or 30s, no one's going to think that you have breast cancer or colon cancer, but you know your body and just insist, something, you really need to pay attention to this.
And you talk about family history. What if any, does DNA or lifestyle play into people's just, I guess, predisposition or just the chances that they're going to fall into one of these categories?
There are a lot of cancers that are genetically related. So probably the most well-known example is breast cancer with what's called the BRCA mutations. I refer to it patients or you may read about the Angelina Jolie disease, because she had both of her breasts removed and her ovaries removed because she knew she carried this genetic mutation. And that she was at a very high risk, in excess of 80% risk of getting breast cancer. So she mitigated it by having this, what we call prophylactic bilateral mastectomy. She had both breasts removed because her mother carried that gene, and her mother died at a young age from ovarian cancer. So genetics definitely plays a role, but with that knowledge, you can kind of fight against that too. And lifestyle habits definitely play a role, and it sounds trite and you hear it over and over again, but weight, obesity, smoking, drinking, all the things,
lack of exercise,
sedentary lifestyle definitely plays a role. And there multiple studies have shown that, and multiple studies continue to show that.
Are you seeing patients that, or I guess a percentage of patients, are you seeing a percentage of patients that are clearly developing these various diseases through lifestyle, or more so DNA?
Well, it could be. In some cases, it can be a combination. But for instance, lifestyle cancers that we are all very familiar with, if you smoke, you're at significantly increased risk of lung cancer. So we still see a strong correlation between lung cancer and smoking. Head and neck and more gastroesophageal type of cancers, which can be stomach, esophagus, anything within your oral cavity, those can be associated with smoking or drinking. So heavy drinking, again. So these are lifestyle choices that you're making that are putting you at increased risk. So, and those aren't necessarily DNA dependent, but some of them do have a DNA association.
Okay.
And then another causative thing that we are learning more and more about is viral infections. So probably the most known one or talked about one is the HPV virus.
Human papilloma.
Yeah, human papilloma virus that can give rise to cancer, or like in women, cervical warts, just warts, which are benign. But that's when they developed the new vaccine, the Gardasil vaccine, to prevent that. So just by vaccinating, boys and girls prior to them becoming sexually active, and they've increased the age at this point to 26, and I think they're bringing it up to 42. And you'll probably see that trend that can prevent cancers of the oral cavity, the pharynx, the throat, the cervix, the anus, and the vagina, the GYN cancers, which is huge, because those even if you catch them early, the treatment isn't pleasant. So if you can prevent, you know, to me, that's the key. And that's a vaccine right there that can prevent a significant number of cancers.
And just speaking of that region, we were talking a bit before the show about head and neck and how those are, I guess, diagnosed. Excuse my vocabulary.
Or staged.
They're staged a bit differently than the rest of the stages are assigned. Can you speak to that a bit? What is the difference there in the head and neck region, and what do those stages mean?
She's the head and neck expert. Let me just go. So just in general, and then I'll let her be more specific with your question. So most of our staging, regardless of the site, is based on tumor size, lymph node status, and metastasis. So we use what we call a TNM staging. The T is pretty much the size of the tumor. So in certain, you know, we usually have anywhere from a T1, and then you may have T1AB, T2, and you may have subcategories ABC, same all the way through T4. So T1 would be smaller than T4 being larger. All right. Same thing with lymph node status. We have N0, meaning no lymph nodes involved, and then you can go anywhere from 1 to 3, maybe with subcategories, and that describes how the lymph nodes look. Then the M means metastasis, and metastasis is when a cancer has spread beyond its original site or the local region. So for instance, if you have breast cancer and we say you have M positive disease, M1, that means it's spread beyond the breast. It may be in your brain, your lungs, your bones, or somewhere else. So our staging is based on a TNM staging system, and then based on your TNM, you can fall anywhere into a 1, 2, 3, or 4.
That makes sense.
Nice. With stage 1 being the earliest. Obviously. And the one thing I will say about lymph nodes we have lymph nodes all over the body. And I like to patients, I'll describe them as like train stations. You know, they're little way stations, and they have the train tracks, the lymph vessels in between that run along with the arteries, nerves, and veins. And that's one of the earliest ways that cancer spread. So like a woman with breast cancer, part of her treatment is, you know, surgery is always a part of that treatment if it's localized, and they always sample the lymph nodes. That helps stage the patient, because if the lymph nodes involved, that takes them from stage 1 to a stage 2 and so on. But the thing we were talking about earlier with regard to head and neck is a lot of the head and neck cancers we're seeing nowadays are caused by the HPV virus that most people are exposed to at some point in their lives. They do not know they have it. There are no symptoms. It's not necessarily sexually transmitted. It can be from close contact. Most people will clear it within 1 to 2 years of being exposed to it. Their own immune systems will take care of it. They'll never know they had it. But some people who are exposed, say at age 20, it will get into their DNA and express itself decades later as a cancer, as a head and neck cancer. But what we have found is in most of those patients, when they come in, the most common presentation usually arises in their tonsil or the back part of their tongue, for example. And they'll come in with a very large lump in their neck, big. But what we found is with combined chemotherapy, radiation together, that a lot of those cancers are controllable and curable. So we're saying, we're telling these people they have stage 4 cancer, because that's what they really are, stage 4A or 4B, but yet their prognosis is very good. It's still a very debilitating treatment to go through, but it's high. So they're rethinking that kind of stage system for like those kind of cancers.
For those regions. And so I just want to kind of be clear here, for those head and neck areas or head and neck regions, if it's stage 4, that means what percent?
If it's a stage 4 and it's caused by the virus, as opposed to the more common ones, like when we started training, most of the head and neck cancers we saw were caused by a combination of drinking and smoking. And even those were very treatable. It was just a very debilitating, the surgery, the chemo, radiation. Because like I explained to patients, head and neck cancers tend to wreak their havoc locally. They don't readily spread. When they do, it tends to be the lung. But even advanced ones, if you can control them locally, the patients have a pretty good chance of survival.
But when she talks about debilitating treatment, I mean, you can imagine if you have like a mouth ulcer. Some of us get cold sores, right? And you know how painful that is. So imagine now that this is actually a cancer.
Wow.
Okay?
Yeah.
And so it can affect your teeth, chewing, taste buds, and the treatment we give doesn't, it's hard treatment.
Yeah.
It's very hard treatment to get a patient to get rid of that tumor. So we actually make your symptoms worse during the course of treatment, but the outcome overall can be very good.
Yeah.
So people end up with feeding tubes. You know, sometimes they end up hospitalized because they're dehydrated. They can't eat. I mean, it can be really debilitating. Skin peeling off. It's not a pretty picture, and I'm not trying. It just isn't. And you know, cancer treatment's not easy in most cases, but the outcome from the treatment is usually very good.
Positive, right? And that's one of the things I wanted to get to was treatment. I know for me and a lot of the people I've spoken to who have loved ones who have gone through treatment, it's just a lot of gray areas. I know you're going to the hospital today and you're going to get radiation or you're going to go to chemo, but I don't know what that means. I don't know what that looks like. I don't know what you're going through there. I know I have to pick you up at a certain time and we just drive home. So what does, I know this is a big cloudy area, but what does, I guess, a standard chemotherapy session look like? And secondly, what is radiation oncology? I think I made a mistake here and didn't let you all define that at the top of the show here. But I would like those to address here. Dealer's choice.
Well, chemotherapy, okay, so a patient, let's say they have a symptom. They'll go to their primary care doctor and say, I felt a lump in my breast or whatever. And the primary will generally start the workup and order whatever diagnostic studies need to be done, and then refer that patient to, usually, if it's a surgical disease, to a surgeon, a general surgeon or a surgical oncologist who specializes in cancer surgery. And then that surgeon will do his job, do the cancer surgery, and then if he's good, he's doing a team approach from the outset, what we call a multidisciplinary approach, where we all meet and discuss the case and say, yeah, we're going to do this, this, and this.
Now, is that not common, or?
It is. It's much more common.
In some cancers.
In some cases.
Yeah. So we have what we call tumor boards, and that's the multidisciplinary approach. So a patient may have a biopsy, so now they have a diagnosis. But before they go forward with the definitive surgery or whatever, we would have a conversation where we have a group that meets. We review x-rays, review pathology. We'll have the surgeon present. We'll have a medical oncologist who gives chemotherapy. We have a radiation oncologist who gives the radiation. We usually have a patient navigator or a nurse navigator, anyone who could possibly be involved in the patient's care. And we sit down as a group and come up with a care plan, what we think is the best plan of action for this patient based on their stage of disease. We all get to see the patient beforehand, so the patient has an opportunity to talk to everyone, get their questions answered, and so they know in which direction they're going.
Or is crafting that plan, with all those, different opinions and specialties and expertise, and everyone has to come together. I can imagine that can be sometimes it is. I mean, even between your own specialty, there could be other radiation oncologists, but the one thing we do have is the NCCN guidelines. That's the National Comprehensive Cancer Network. And so it kind of gives you flow charts, and it kind of gives you a general idea of what to do for a patient with these factors, what to do with a patient at this stage, that sort of thing. And so that's always a good starting point. But as I'm sure we'll talk about in a little later, is how individualized things are now. Right.
So the patient, because sometimes the patients, if they have a more advanced cancer, they'll get chemotherapy first to shrink things down. So that it makes the surgeon's job easier. So the surgeon will, let's say, just for argument's sake, see the patient, do their part, and then they'll send the patient for chemotherapy if that's indicated. And what that usually entails is, a lot of times, instead of starting an IV, because most chemotherapy drugs are giving IV intravenously, or more commonly now pill form, which is fantastic for patients. But a lot of times they'll get what we call a port, a little implantable device into their chest through which they can get their chemotherapy for each cycle. It just makes it easier access. And so they usually go in, the patients are usually pre-medicated, and I think that's what patients are pleasantly surprised about nowadays, is how well they tolerate chemo, because a lot of the side effects that people commonly associate with chemo are alleviated by these pre-medications. And then they get the drugs. They're there for anywhere from 30 minutes to several hours. They're hydrated, and then they're given medication to go home with, and then they come back, either they're getting it weekly or every 3 weeks or something like that. That's generally how chemo works. Radiation, on the other hand, is what we call a fractionated treatment. We give a fraction per day, each day, 5 days a week, over a number of weeks, anywhere from nowadays 5 days to 7 weeks. So the patient comes in each day. I usually tell patients they'll be there maybe half an hour, 20 minutes a day, but the time they're actually laying on the table getting a radiation treatment from a machine is about 10 minutes.
Yeah. Interesting. So how would you all describe your day-to-days, I guess, if we're on an average day? What does that look like for you?
As a doctor or as
doctor.
a patient? Okay.
As a doctor.
Well, in radiation specifically, I mean, we both work for the same group, different offices, and we may have anywhere from 20 to 40 patients on treatment. But those are patients who we've already seen, we've already come up with a treatment plan, whatever. So they're coming in every day, getting on the machine, getting their treatment. We may pass them in the hallway and say hi, but we're not pushing the buttons, okay? But we're still in charge of their care. So we have to check their films that are done to make sure they're getting treated the way we want them treated. At least once a week we meet with them in an exam room to see what kind of side effects they may be having, if there's any intervention needed. So that's routine for everyone who's on treatment. Other than that, when a patient finishes treatment, we still follow them in follow-up. There are guidelines in terms of how frequently you should see a patient, because we want to stay on top of this. So if there's any signs of recurrence, we're on it and we know what to do next. So we see patients in follow-up the first year, maybe every 3 to 4 months, eventually every 6 months, and then ultimately once a year. And we follow patients for up to 5 years or beyond, because sometimes at 5 years patients want to continue seeing you, so I'll continue seeing my patients once a year if they'd like. And then other than that, we're doing new patient consults. All right, so that's part of our schedule too. So when a patient is referred for radiation, we see them in consultation, where we will review their pathology, their x-rays, their history, and then get them started on the right path for treatment. So
wonderful. When you have these new patients, we spoke about this a bit before the show. What do you recommend for those first interactions? I'll ask it like that. I want to start with you.
Well, and we both agree with this 100%. I always feel that when a patient hears the word cancer, they don't hear anything you say beyond that. And they have so much information that is being thrown at them that it really is in their best interest to have someone with them. A loved one, a family member, friend, advocate, someone that can hear everything that they're hearing. Like, for example, Jackie did a clinic this morning, breast cancer clinic. And that's where newly diagnosed, so these women have literally just found out within the last couple of days to a week that they have breast cancer. So this is a clinic where, like she said, there's the surgeons there, the radiation oncologist, the medical oncologist, the geneticist, if the patient has a family history, needs genetic testing, and plastic surgeon, so they're getting a lot of information thrown at them. There's no way they're going to remember all of that. So after they go through their treatment, you may not see them for a couple of months. So it's important when they do come back that you reiterate everything. You go over everything again, especially with what we do, because most people, they don't have a clue as with a radiation oncologist. They don't know. They think we put electrodes on people's head,
or that they're going to be radioactive,
right? And that's a very.
Am I going to be green? Am I going to glow? Can I be around my family members?
And patients won't ask that. They'll worry, can I sleep with my partner? Can I hold my grandchild. And so I try to always emphasize that to them. You're not radioactive. You're only being exposed when that machine is on. Once that machine is off, there's no radioactivity left. You know, you don't pose a threat to anybody.
But then there are some types of radiation that we do treat with, where people will ingest a capsule and they are radioactive.
Oh, wow.
Or we may put seeds, prostate seeds, or seeds in, you know, different parts of their body, and they are radioactive for a certain amount of time. So we do radiation precaution for those patients. But the average patient is not getting that. When they're coming in for x-ray therapy on a daily basis, it's just like having an x-ray taken.
Right.
Okay.
Right. And when patients are asking questions like, am I going to turn green? Am I going to be radioactive? You know, beyond that, do you find that they're asking enough questions or the right questions? I know that can, like you mentioned, it can be overwhelming. And I know a lot of people have the tendency to fold up whenever they feel the pressure, right?
You are so right.
Yeah, I mean, it varies. Sometimes I can tell, and as a doctor, you can sort of, if you take time with your patients, you can gauge
their tendencies.
Right, and you can get to know a patient. So I think we as physicians need to go above and beyond. We shouldn't expect the patient to ask all the right questions or the questions that we know that they need to have the answer to. So I think you should, as a doctor, we should supply enough information. If they're not asking the questions that are important, we should give them that information without waiting on them to ask.
Yeah.
So.
What role do you think, or have you seen a positive attitude play into treatment?
Huge.
Yeah.
Tell me more.
With regard to side effects, managing side effects, just it doesn't matter the age of the patient, but a positive attitude. It could be the oldest elderly patient,
Sure,
you know, they just have this positive attitude. I've just seen it over and over. I may not be able to articulate it well, but those patients tend to tolerate treatment better, fare with the side effects better, and typically have better outcomes. And I think there have been studies to show that.
And I mean, I'll tell my patients too, you know, and I like to say attitude and everything can be almost 80% of it. And because if you have been diagnosed with cancer and you're getting the treatment, you may not feel great on certain days. That's okay. I try to get patients not to take to bed. Don't get in the bed and pull the covers up. And you know, because those patients tend to go down a lot quicker. You know what I mean? Try to maintain your lifestyle. Try to do as much as you can tolerate. Continue to eat. You may not want to eat, but you have to eat. You may change what you eat. You know, now I'm telling you, you're barely eating once a day, and I'm going to encourage you to eat 6 times a day, you know? But you have to do certain things to get yourself through this. So if you can keep a great attitude and really work with us, we try to get you through it.
And what are some of the things, you know, outside of maybe those are it, but patients or loved ones even can do to empower the patient, to make them feel like this process is going to be beneficial, it's going to be worth it, we're all in your corner, you know, you're not going through this alone?
I think just that, you know, just being there, you know, I kind of look, when I'm talking to patients, I say, okay, this is your job. I know you don't feel like eating, the whole eating thing, you know, I say, but you have to look at food as a medicine now, and it's a medicine you have to take, you know, but if you can unburden a lot of your day-to-day things to your support system, and then that plays a role too in terms of getting you through the acute phase of it anyway. And I think a lot of emphasis now on cancer is the importance of the mental well-being of the patient, taking care of that too. And you'll see more and more cancer centers, you know, incorporating that into their practice. You know, music therapy, art therapy, meditation, yoga, massage. You know, it really it's a holistic approach, and it's about time.
And also, I mean, support groups. There are support groups, right? And not just for the patient, but for the family members too, because cancer involves the entire family unit. It's not just the patient that's affected by it. So to know when you need to reach out and ask for help, when you need support, when you need someone just to talk to, I think support groups are really important. So that's something else.
Absolutely, especially with cancer not being the death sentence it once was, right? And we were talking a bit before the show again about this, but speak to there's curing and then there's treatment, right? And I think a lot of people get confused when, first of all, they hear the word cancer and the walls go up. They think this is it. But then for some folks, this is it could mean a beautiful life with years or months or even, time still well spent with your loved ones. So what is the difference between treatment and cure? And how were those assigned, I guess, with stages? Does that make sense? I'm asking that. Jackie, you want to start with
Okay.
this?
So, early stage cancer, usually the goal is cure. Okay. So we feel like stage 1, stage 2, stage 3, for the most part, our goal is to cure this.
Sure.
All right. The earlier the stage, again, stage 1 is very likely, and the higher the stage gets, the less the chance of
right.
cure. I won't say it's impossible. Okay. So then when you look at stage 4, and even we're talking more what we call palliative care, right?
Okay.
So we're palliating symptoms. We're trying to help relieve pain. If you have a large mass, we're trying to shrink it in size, so we want you to, so it's more like quality of life at that time, not
Sure.
necessarily quantity.
Sure.
Okay. So with radiation oncology, with medical oncology, with cancer in general, we have palliative care services. We also have hospice services. And so again, as you get more advanced with your stage, it's good to bring other services on board.
Okay.
All right, especially if you're a stage 4 patient, where again we're looking at quality, not necessarily quantity. That's when we start talking more about hospice care. Okay, so we can still do some types of treatment for as long as we can, but at some point we may want to bring hospice in when we know treatment really isn't working anymore, because we want you to have a good quality of life.
Right.
And one of the things that we as physicians are guilty of is waiting too late to get hospice involved. Right, so that's
Is that
something.
just faith right there?
Well, and just because we want to do everything we think we can do, but at some
We're
point,
human.
right? At some point, it's only so much you can do. So, and I've actually had patients that have gone on hospice, and I've had the hospice call me a year later saying, "Can they come off now?"
Yeah.
They're still, and so people can go on and off hospice. Hospice doesn't necessarily mean you're dying
is it.
tomorrow,
Right.
and that's what we want people to understand. Then there's palliative care, and palliative care is not just necessarily for cancer. Any chronic illness, you can use palliative care services,
Okay.
and that means they're going to talk to you about pain management, about eating, about doing things to palliate whatever type of symptoms you're having. So palliative care is another service that we should use more frequently. So these are all things, but again, in terms of stage, yes, we think of the earlier stages we're trying to cure, the later stages we're trying to help control and improve the quality of life.
And as you go up for the stage number, are the chances of regression higher as you increase, or how does regression relate to stages, if they do relate?
You mean response?
Like remission?
Remission. Excuse me.
Okay.
Yes, wrong word.
No, because regression means a tumor can be getting smaller.
Smaller.
Right.
Okay, so
Okay.
we
Exactly.
do
So
see
you could have a large,
regression.
Okay.
right, and
Okay.
see that. And but again, the earlier the stage, the earlier the disease is caught, the greater the chance that there will be long-term control and cure. But as things change, even earlier on in my career, I never like to talk about because number one, I say, well, I'm not God, so you will have a stage 4 patient come and see you 5 years later and say, "Oh, doc, you're shocked to see me.
Right, you told
Didn't
me.
think I was going to be here." So I've never felt comfortable saying, "Well, I'll get my things in order. You've got 6 months," a hard number.
Right.
Because there are cases now where cancers are turning into more like chronic diseases, kind of like HIV, with proper management. And a lot of it has to do with the newer therapies that are rolling out that we're seeing get into major practice now. So, but the earlier it's caught, the greater the chance of that you will put this behind you for good.
And when you talk about remission, I mean, I hate to say it, but once you're diagnosed with cancer, it's pretty much like a lifelong,
Right. Okay.
lifetime illness, right? We may cure you quote unquote, or we may put you in remission,
Right.
but you're going to have to continue following, watching lifestyle, doing things to make sure you stay in that state. And sometimes, regardless of what we've done, even though we may think we have cured you,
Right.
cancer can come back 20 years later, unfortunately, you
Yeah.
know. So yes, people can have they can have cure where it never ever comes back, or they can have really long remissions.
And that's the point I was getting
Yeah.
to with that. It's not really gone, right? And
Well,
you
it
wanna-
is gone. I
It
mean,
is gone.
that's
You
Right,
can
okay, so-
survive. You can survive to have another cancer.
Cancer.
Okay.
You
That's
see what
where
I'm
I was
saying?
going.
and you can survive for the cancer that you have to come back. So
Okay.
sometimes, especially, and I don't want to scare anyone, but in breast cancer often we see where we've had patients who for 20 years they've been totally disease free.
Wow.
And then all of a sudden, you know, is that a new cancer or is it the same cancer that's come back? You know.
And so is the behavior to kind of keep it at bay or keep it away, is that the same as the preventative behavior that we spoke about at the top of the show here?
It is. And also to keep up with the screenings, which the general population should be doing anyway. That's what I
Right.
tell the breast cancer patient. I say, your screening is ultimately not going to be any different than any other woman's. It's going to be that mammogram. That's going to be the start.
And self breast exam. So.
Are there different screenings for each kind of, or like if I wanted to do something that's all encompassing, is that possible? To just test everything. I just want to make sure.
You know, there are some whole body
scans.
scans that people are paying to have done. In general, your insurance isn't going to cover that.
Right.
You know,
I'd imagine.
unless you're an executive, they do have some
Yeah,
executive
executive.
plans that do that, and that's because companies have invested a lot in you, and they want to make sure. You know, but an average insurance policy does not cover for a whole body scan. So you would have to follow the guidelines site by site for what screening would be.
And folks should go to their primary.
The primary care is what we call the gatekeeper. So
Right.
yeah, they sort of manage that. I mean, if you're a woman, then your gynecologist might be doing it as opposed to your primary care.
Okay.
But in general, yes.
Okay. Because that's one of the things that, at least for me, is important. I know black males don't go to the doctors enough. So are you seeing a higher population of that demographic because of that? Or is it more so just kind of a general kind of mix of folks?
I'm not really seeing a lot of young black males other than like the rectal cancers, which scares me to death because they don't really know. I mean, they
Right.
speculate. Maybe it's the generation, their dietary habits because of all the processed food that we eat. And I wouldn't be surprised personally. I think
Interesting.
that
Yeah.
that's playing a role. But
I would say prostate because I do some work at Howard. Okay.
Okay.
And so that's definitely a large minority population. And so I would say in my practice between the places where I work, I have seen younger African American men come in with prostate cancer. And I think one of the things, I mean, we have mixed messages with some of our screening guidelines, especially prostate. That's one that's changed, and I think African American physicians aren't necessarily in favor of what the screening guidelines are. So for prostate cancer, at one time we said all men over 45 or 50 should have the digital rectal exam and a PSA annually. That's no longer the case. Now it should be a discussion between you and your physician as to whether or not you'll be screened for prostate cancer. So we're saying, I know, right? I see your face like, why would you do that, right?
But also, how do those guidelines get
There's
changed?
a task force that's appointed that reviews everything. And the task force comes out with guidelines, and then the American College of Surgeons may support it, the American Cancer Society may support it, or they may say, well, no, we disagree, and these are still our guidelines. So doctors need to be familiar with the different recommendations, but prostate cancer is one where the guidelines have changed, and now it's, unless you have a family history or some risk factors, it really is more of a discussion between you and your doctor as to how you want to proceed. Which to me is detrimental to young African American men, because if you don't bring up the question with your doctor may not raise the question with you, and you know. So.
Do you all have any recommendations for low income or, I guess, parts of the population that may not have consistent access to a primary? When just, I guess, we're talking about cancer, so for that specifically, but just in general as physicians.
There are a lot of resources in the county here and in DC for low-cost screenings. There have been a lot of resources placed into that for low-cost mammography, for health screenings at health fairs, for men, PSA, the blood tests to look for prostate cancer, and they'll have urologists and surgeons and oncologists volunteer their time to provide that service for people.
Yeah, I think you, wherever you live, because you may not be in Washington, D.C. watching this, you can check with your local health department where there may be free screenings going on. You'll find oftentimes that churches sponsor free screening or free workshops, and again, you'll have physicians on site there. You may have different companies there that are actually doing Mammo Day or PSA or, you know, different things. So there are resources, but a lot of times what happens is that will get you screened and maybe diagnosed, but then the treatment is a different thing.
Right.
But once you've been diagnosed with a cancer, there are resources put into place to help you get insurance of some type to get through the treatment of it.
Is that usually through some sort of provider or the...
Through Medicaid. Mostly, yeah.
Okay.
But again, at that point, you may be placed with a social worker or a case manager or something who will help walk you through the guide.
Wonderful. And we talked about earlier here having that person with you when you're receiving all this news. But just for the patient, are there things that they should absolutely know just within them? I know you probably have a laundry list of things that you're giving them, but are there maybe 4 to 5 things that they should just carry with them every day, just knowing, okay, I'm getting through this, I need to make sure I'm doing this, I'm taking my medicine, eating, are there things that they can do to make their treatment easier?
I mean, sometimes even keeping a journal, a notebook, if something pops into your head, you're not necessarily at the doctor's office, write it down. So keep a notebook with you. You can take notes, or you can have someone take notes in your notebook, or you can even ask your doctor or the nurse, can you write that down for me? So when you're no longer in the office, you can go back and look at it and say, okay, if there's something you don't understand, don't be afraid to ask. All right, please. There's no stupid question. All right, this is your life. Right, right. Don't be afraid. Don't be embarrassed. Make sure you understand everything that's being told to you. And doctors have a tendency to talk in doctor language. If you don't understand doctor language, let the doctor, sir, ma'am, I really don't understand what you're saying. Can you explain it to me so I can understand? And if you have a doctor that's not willing to do that, you should be looking for another doctor. Okay.
And which brings up another thing, and don't be afraid to get a second opinion. There's nothing wrong with second opinions. In fact, most doctors welcome second opinions because it reinforces generally what they're telling you. So I find I don't like patients to be intimidated by their physicians. We're here to serve you, and just take care of yourself, rest, eat, hydrate. Use all the resources available to you if you're working. Like I'm always talking about patients, because they're worried. Like I don't know about if I can take this time off. That let me just write any letter I need to write for you to your supervisor, whatever that will make this journey easier.
Right.
Just take advantage of it because that's what we're really there for.
Absolutely.
And with FMLA, family leave, I mean, when a lot of times patients don't want people to know what's going on. All right. But you have resources available to you. So go to your human resources if you're working. Find out what benefits they have for you. What you can do in terms of taking time off to get the treatment you need. And once you've been diagnosed with cancer, it's good to be an advocate. Talk about it. It's nothing to be ashamed of.
Right.
So talk about it. Talk about it with your family members. Talk about it with your coworkers, with your church members, because you could be a blessing to someone else by sharing your experience.
Absolutely. And speaking of experiences, we've talked a lot about the patients and about the kind of the hard stuff here. What is your favorite part of your job?
Gratification. Get from the patients. Patients are very grateful. You work this. We're in a unique specialty because we see patients pretty much on a day-to-day basis for, up to 2.5 months at a time.
Right.
So you really do form relationships. You see these people out in the community, they become part of your family. They come back, not just in follow-up. They'll come back, look, doc, that is the biggest gift.
Yeah.
Seeing a patient you treated 10, 20, 30 years ago and living their life, their best life.
And I mean, truly, we do see patients that I still, because we both trained in this area, I run into people all the time that I see when I was in residency treating them. And that's a really good feeling to know that what you did made a difference.
Yeah,
These people are still
absolutely.
here.
Absolutely.
So,
And one of the things I like to try to make sure that I get across here is when I'm talking to people, if not through just the questions I'm asking and getting the responses, but having them share their experiences, right? For any little girls out there that are looking at you too, my doctors have been black my entire life, so I know nothing else. And she's been a woman my entire life, so all I know is black female doctors. That's all I've seen. What would you share with the little girls out there that say, hey, I want to be a doctor and I've never heard of radiation oncology before? What should I do to maybe prepare for that? Or where can I go to learn more about it?
Reach out and meet one. I mean, I do get calls. I have mentored I have 2 sons.
Okay.
So some of their female classmates, they'll come and do, like in high school, spend some time shadowing me.
Sure.
When I came to it because a family friend contacted me when I was in medical school and said, well, what do you think about doing? And I said, I don't know what I want to do. I know what I don't want to do. And he said, here, I want you to meet someone at Howard University. Her name was a good friend. She's one of my closest friends now. And she trained me. She was my mentor. She continues to be a mentor. And so I didn't have any more what we call class time to spend. So I just took my vacation. I took 3 weeks of vacation and came and spent it at Howard University following her around.
Yeah.
So people, we love to do things like that. So read any information you can, but try to make contact.
right. Same thing. I have people who, their children may be in middle school, high school, and they want to be a doctor. What do you talk to them? So we talk to them freely. We let them come to our office. They can spend a day with us if they have more time and they're a little older, then spend more time with us. So as I said, I'm still on faculty at Howard, so we don't have a residency there anymore.
Okay.
But I have medical students who've never been exposed to radiation oncology.
Sure,
So
sure.
even though they can't do a rotation under me, when I'm there, they'll come and hang out for a morning or for the afternoon just to get exposure to the residency or
Sure.
what the department actually is, what radiation oncologists do. Because usually oncology, especially radiation oncology, is tucked away somewhere in the basement of both facilities, or
Yeah.
so it's not a well-known specialty. And when Alison and I trained, we both trained at Howard, and Howard was really training the majority of African Americans in radiation oncology at that time. Things have changed now, and we are in programs all over the United States.
Wonderful.
So.
And any advice for our med students out there?
Consider radiation oncology as a specialty. It's a great specialty.
It is a great specialty, and if you're in medical school, it's a very hard residency to get. You do have to do some research. You have to publish to really, make yourself competitive for this specialty. So things have changed significantly since we were in the residency. But it is a great residency. I think you would really enjoy the specialty long term. So
It is a very, very exciting time to be in oncology in general because of all the changes. The whole new immunotherapy, where the whole research now is harnessing your own immune system to attack your cancer, to make vaccines, personalized vaccines, taking your cancer cells out of your body, making a vaccine, injecting it back in,
and watching it do its
job.
That's interesting.
Yeah.
Have they started those trials already? Interesting. And so, anything else we should be looking forward to in the space?
Well, everything's becoming personalized now, and it's been like that. It's getting increasingly like that, where, for example, like back to breast cancer, for example, they take the tumor and they do all of these studies on your tumor cells to determine, well, which drugs are going to work best in you, that sort of thing. So, and a lot of these newer chemotherapy drugs are what we call targeted therapy. So they're targeted toward the cancer cells and not necessarily all of the healthy cells. So that's why chemotherapy patients lose their hair or they get sick, you know, because of the cells lining the gastrointestinal tract. These targeted cells, these targeted drugs, you know, they target the cancer cells so they don't affect them. So a lot of those patients, they don't lose their hair or they don't get nauseous or diarrhea or sick.
And that's one thing too. So from a patient standpoint, and in the clinic I was at this morning, there was a patient I was talking to, and she's going to need chemotherapy based on her tumor. Okay, but patients have, you know, well, my friend had it, and it did this, and it did that, and I don't want this, you know.
Very good.
And I'm like, but your friend had it, and your friend's still here talking to you about it, right? So whatever she had, no, but I mean, so I'm saying she lived through it. Right, so no matter how bad the chemotherapy was, that friend is still here, able to talk about it. All right, so don't be afraid of a treatment based on a story you've heard from somewhere else.
Horror stories.
All right, talk to the doctor, have a good understanding, because like Alison was saying, things have changed from where they were 20 years ago or 10 years ago, even 5 years ago. All right, the side effects may not be the same, and we are individualizing treatment, so it's not a cookbook or, you know, you have this and this is what we do. No, you have this. We look at your genetic makeup. We look at what's best for you and how we can treat your cancer. So.
And just like you said at the beginning, the treatment may be painful, but the result is what we're looking for. That's the goal, and the result is
to continue to live a healthy life.
Exactly.
Yeah.
I want to thank you both for joining me on the show again today. I've learned a lot of information. I'm going to have to probably rewatch this just so I can actually do some retention here. But I do want to thank you, Dr. Alison Brown, LaVigne, and Dr. Jacquelyn Dunmore Griffith. I want to thank you both for joining me.
Thank you.
This has been a great show. We have had a great show today. I hope you all have learned just as I have. Remember, you can watch a recording of the show on the Book It Now Facebook page or head to the WBGR Entertainment channel for a review. And again, if you would like to be a guest on the show, you can visit our website, www.bookitnowtv.com. I want to thank you all for joining me again today. And remember, like I tell you every week, if no one has told you that they love you today, remember that I do, and I always will. Good night.